So just a word about the collaborative before I say any more about the event. The collaborative for better health and regulation represents a shared ambition by Melbourne Law School, Melbourne Medical School and Melbourne School of Population and Global Health to ensure that regulation serves the needs of society and constructively enables activity to improve population health and healthcare. To put it simply, the collaborative has as a central ambition to enable better health and healthcare through better regulation. I'm Professor Mark Taylor. I'm one of the directors of the collaborative, and on behalf of myself and the other directors, Professors Megan Munsey and Marie Bismarck, I welcome you to this event and sincerely thank you for joining us this evening. The collaborative events provide us with an opportunity to come together across school and disciplinary areas to explore and understand how together we might work to make things better. Last year we started considering the issue of when should we be taking a second look at a child's health results? When should we be recontacting families in the results of what we learnt through the reanalysis and reinterpretation of a previous test result? As it's become possible to store data for longer, to share it more easily, the question of when previous test results that sit in the systems, when they should be reanalysed and reinterpreted in the light of new knowledge to yield new information, and when patients, families and carers should be recontacted and told about the new information which has become available. Those questions about when we should do that, how we should do that, they've assumed increasing significance. So we started to consider some of those issues last year, and we thought it would be useful to return to those issues, but this time look at them through the lens of, or look at them in the context of an area where a lot of thought has been given to recontact and reanalysis, and that's the area of genomic data in particular. By looking at how some of the challenges we identified previously, how they're being tackled in that particular context, we hope might enable us to share an understanding of good practice that can help understand how we do it in case of genomic data, but also where it's appropriate to map across learning, it might contribute towards that conversation we're having about reanalysis and recontact more generally. So, to help us understand some of the opportunities that there may be to move toward that common understanding of what constitutes good practice in relation to reanalysis and recontact, we've got some wonderful speakers for you tonight. There are some short speaker bios on the table before you, but to keep as much time as possible for discussion, I will introduce the speakers very briefly, leaving you to read a little bit more about them for yourselves. So first of all, can I please welcome and introduce Professor Zornitza Stark, a clinical geneticist working at Australian Genomics and the Victorian Clinical Genetic Services. So Zornitza is going to give us a bit of an introduction into the reanalysis of genomic data, why it's important, the value of doing it, and some of the issues that are raised by it. Over to you, Zornitza.
Thank you very much, and thank you for the kind invitation to speak here today on this topic. I see lots of familiar faces in the room, and I think there's lots of people here who know a fair bit about genomics, but it is always useful to think back on the fact that the first human genome sequence was generated 20 years ago. That effort took 10 years and cost billions of dollars. We now live in a world where we can do the same in just a few days for a few $1,000s, and that's what's brought genomic sequencing into the realm of it being a clinical test that we can apply, particularly to improve the care of individuals, especially children affected by rare diseases, but also in cancer, infectious diseases, and there's lots of other applications that will be developed over the next few years. But genomic sequencing is a little bit different to other pathology tests that we have in the healthcare system. In particular, the idea that really we should be generating the genomic sequence of an individual just once in their lifetime. So this is not a test that really should be getting repeated. The genomic data are typically stored And another inherent characteristic is that interpretation of that genomic data changes over time, and that is because we're still in the process very much of learning how best to analyse it and how to interpret the findings. So we're still on that very steep learning curve, and that is absolutely not the case about our ability to interpret X-rays or MRIs or look at slides, because the knowledge that we have to interpret those sorts of anatomical structures has been around for hundreds of years. So we know that if we go back to stored genomic data, particularly from individuals who did not receive a diagnosis the first time the test was run, that is highly, highly effective at producing new diagnoses over time. It is the one intervention that we have that increases diagnostic yield significantly over time, and we're talking about 10 to 15% increase in diagnostic yield if this process is repeated every couple of years. And there's over 30 published studies demonstrating this, totaling over 10,000 patients. So the evidence that this works is really strong. And there's been a number of position statements published, and they all suggest that this is a good idea and improves patient care, but they've been a lot less specific about how we might achieve this in practice. And from those studies, we have also learned what are the biggest contributors to that increase in diagnostic yield over time. So we actually have a really good understanding about what we need to do. By far and above, the biggest contributor to diagnostic yield is the fact that we're still discovering which genes cause disease in humans. So to put that into perspective, around 200 or 300 new gene disease associations are still being published each year. So the rate of that knowledge growing is really very fast. The second thing that is still changing is our understanding of which variants in a particular gene cause disease. And again, thousands and thousands of new assertions to that effect are being deposited in large international databases that we use for the analysis of genomic data each year. So that knowledge is also growing very fast. And we're also becoming much better in how we analyze the data. So over time, our bioinformatics pipelines have improved, and we're able to detect different types of genetic variation with confidence. And very occasionally, the clinical information about an individual also changes, and that just puts a different perspective or different lens in how we look at the genomic data. Now so the evidence is really good. We know we should be doing this. We know what needs to go into the process. And we have, to some extent, managed to even convince the Australian government that we should be doing this. So there is some public Medicare funding now available for reanalysis that has been tied to Medicare approvals of particular genomic tests for specific clinical indications. Now, so that was a win, but at the same time, it is actually still very restrictive. So the funding is limited to 2 cycles only, so we're only allowed to do this twice in somebody's lifetime, and the original test should have also been funded by Medicare, and we're only allowed to report new things rather than reinterpret what was on the original report. So even though that funding's now been in place for 2 or 3 years for some of these genomic tests, the uptake of it is actually really low. So when we looked back at the uptake for one of these, there were only 12 requests to reanalyze data in the first 12 months in the whole of Australia. We've also gone around our diagnostic laboratories in Australia and tried to gauge how much testing they're doing. Predictably, the amount of testing that we do each year is growing and growing and growing. Typically, between 30 to 50% of patients who are tested receive a diagnosis the first time around. So the volume of data sets that are stored in diagnostic laboratories in Australia that they haven't got a diagnosis is growing each year, and this is in the thousands. And the sad blue line at the bottom represents the volume of reanalysis that's occurring. So back of the envelope calculation, we are sitting with something like 14,000 unsolved data sets. And if we continue doing what we're doing, it will take us 70 years to reanalyze the data. Of course, that's a nonsensical calculation. And basically what it means is that most patients that could benefit from reanalysis are not going to do so if we continue doing it the way that we currently do it. We also did a workforce survey of clinical and laboratory staff involved in the analysis of genomic data and asked them what are the current barriers, why isn't this happening? And the principal barrier is workforce, so we haven't really kept up with our technical ability to generate that data to have the skilled personnel to deliver the testing. So both on the clinical side and the laboratory side, there's workforce shortages, and that's by far the biggest reason, but also cost, process issues, lack of guidelines and practices, needing these constant requests for re-referrals and initiating the process, which makes everything complicated, etc. So what we and many other people around the world are thinking is that we need to move away from the current model, which relies on individual clinicians to make specific requests for individual patients. So that's a manual request that then goes to the laboratory, and the laboratory performs a manual reanalysis. That's hugely inefficient and only benefits a tiny number of patients. And we need to leverage off something like automation and move to a different model where automated reanalysis is happening in the laboratory in the background. If something interesting that looks like a potential diagnosis is identified through that process, then the laboratory assesses it and feeds it back to the clinician, who then feeds it back to patients. And a process like that would actually benefit most patients. So as part of that groundwork that we did to try and understand what's happening before we did anything, we also worked very closely together with Danya and her team to try and understand different perspectives in terms of what we're proposing. So Danya's going to talk briefly about professional perspectives on what we're suggesting.
Hi, my name is Dr. Danya Vears. I'm a Principal Research Fellow and Team Leader at the Biomedical Ethics Research Group at the Murdoch Children's Research Institute. And I look a lot at areas around genomics and ethical issues around that technology. So as Zornitza kindly set up, we actually we work very closely with our team. We had an ethics stream of this project, which was looking at 3 different samples. So we wanted to talk to different populations about their perspectives. So we actually spoke to patients and carers around the issues around automated reanalysis. We spoke to members of the public, and I'm going to present some data about the workforce that we talked about just now. So we wanted to think about what members of the genomics workforce were thinking around automating reanalysis and what kinds of things they would think would be barriers and what might be helpful. So we recruited, not by Facebook, I'm not sure why that says that, sorry. We recruited through networks and we wanted to screen for eligibility and diversity. So we tried to get as many different people from different areas. So we wanted to look at laboratory staff and also clinicians, and we managed to get a bit of a spread of those. We did focus groups, which lasted an hour and a half, and they were actually online because of COVID, but also because it meant that we could actually try and get as many people from different states as possible. So we recorded those and analysed the data. And I had a good team to help me with those processes. So what we did was we presented this workflow to them and we said, okay, so this is how it would work. And we wanted to sort of point out some of the pinch points and then discuss those in more detail. So we said, okay, you've got a bunch of unsolved patients. We think about how this automated reanalysis might be triggered. Is it a continuous analysis, or is there some kind of thing that triggers it in terms of like the condition or new developments in the field? We had to talk about consent. And would there be enough consent already for these patients, or do we need to get reconsent? And then the reanalysis would happen, but then we need to think about how results would get back to the clinicians and then eventually to the patients. So we want to talk about all those things. So in terms of the results, we managed to get 21 participants across 6 different focus groups. And you can see that we got a spread from different parts of Australia, which was great. And then you can see here that the green is people who are laboratory people, so genetic pathologists, medical scientists, etc. And the blue is actually clinical people, so genetic counsellors, clinical geneticists and trainees. So we got a good spread across the 2 areas, which was really great. And we did it so that we actually had some focus groups which were just genetics laboratory scientists and some people were just clinicians, then we mixed them up as well. So we got sort of a bit of cross-pollination there. And that helped with the discussion. So I'm just going to present areas, like 2 main areas today that were real pinch points in this process. And the first is consent, and the second is around recontacting participants. So I'm a qualitative researcher, so we present quotes. So I'm going to do a lot of reading out of people's perspectives for you. But one of the things we asked to begin with was, do we actually need to obtain reconsent from patients for automated reanalysis? or is the existing consent that they've signed sufficient? And some thought that the initial consent did cover automated reanalysis. So this genetic counsellor said, the ones that I have been involved with even then, it was part of the initial consent to testing, so it wasn't like a reconsent once they got a negative result. It was more like, if you do get a negative result, this will happen, and so you discuss all of that up front. So then you can touch back on it if they do get a negative result. And some of the participants felt that the patients already thought this was happening, so that this was just a process that was ongoing. So as this genetic counsellor said, they think that we're already doing this. So they're often, when people call me and say, just wondering if there's been anything new found on the genetic testing, for those that are interested and see the value of the genetic diagnosis when they call me. Some thought that this might be a surprise, that maybe they didn't realise that the reanalysis was happening, but they didn't necessarily think that was a bad thing. So as this clinical scientist said, if I'm the patient, how would I think about further down the track suddenly getting contacted and they said, oh, we found an answer? It would be a surprise, but I think it's a good surprise in a way. On the other hand, some of the participants felt that we actually didn't have enough consent and that people might think this was beyond the scope of what they initially signed up for. So some people said that's because the initial consent doesn't cover reanalysis in a lot of detail. So as this genetic counsellor said, I don't think all of those cases would have been consented in enough detail to be aware that that was happening or to not be surprised if they were contacted about a result. Some felt that because it was an automated process, some of the patients might not be okay with that, not knowing it. So this clinical scientist said, I'm not sure how people would feel about that. Something or someone is interrogating your data continuously. Whereas for others, they thought that things like changes in patient status might be a problem. So for example, in this instance, this clinical scientist said, worst case scenario, that child is now deceased and they don't want to be reminded of that time in their life and they're no longer interested in the genomic results. Similarly, there might be instances where that patient who was consented as a child by their parents may be now an adult, and that might be an issue in terms of recontacting them. So this clinical geneticist said, one point is just, again, the process of reanalysis in an individual, say, who may have had testing initiated as a child, but is now an adult, and they may have different views. And along those lines, if that does happen, and say the child might have had some kind of intellectual disability, how do we know that we can actually gain reconsent from that child when they've reached adulthood? So this person said, even figuring out whether a person has capacity to consent can be tricky too once they turn 18. Some would be very obvious that they don't, but some would fall in the middle. Then we want to talk about how we should obtain consent or reconsent from patients for automated reanalysis. And there are different models that you can take. And one of them we talked about was a patient opt-out model. And that was favoured by some. So this clinical geneticist said you could reach out to them in some form and say, this process is happening again. I don't know the specifics of this, and you'd need to workshop it, but something along the lines of putting back the onus on the patient. This is happening. If you would like to know more information about this or opt out, please recontact us and let us know. And then you could just assume that for the people who haven't responded, but perhaps that's their way of offering consent. Having an opt-in model where you actually have to require patients to come back to you and say they want to be involved is a lot more labour intensive. So we talked about needing resourcing for that. So this immunologist said, you can pay for a staff member whose job is just to sift through all the new results that come out, and then you can make an opt-in model. But then we also talked about dynamic consent. So dynamic consent is where you might have a platform that allows patients to continuously change their preferences. So they get maybe some kind of notification, and they can go in and change and say, yes, I want to have reconsent done, reanalysis done or not. So that was a model that people favoured quite heavily. This clinical scientist said, I think dynamic consent is a good thing, a good development in this area, instead of just obtaining initial consent and then carrying that out for 10 years or however long we're going to be keeping and analysing this data. We then talked about when we would go through this process about obtaining reconsent from patients. So some people said that should happen at the consent for the initial test, and then that was when this would be appropriate. So this person said we should be discussing that with patients then when we do our consent. But obviously, as Zornitza just highlighted, there are lots of cases where we want to go back and reanalyse that we don't have this initial consent for, or that we may not have sufficient consent for. So some suggested that maybe when we have it, when you've received a negative or inconclusive result, that might be the time that you talk about it. So this person said, I think that we would need to do this is flag that with them at their result discussion. Others suggested that maybe it might be appropriate to do it when a reanalysis is triggered. So for example, if it's not a continuous process, if it's something that happens occasionally, maybe that's when you go back to the patient. This clinical scientist said, I do think an electronic form or even like replying yes to a text message or something like that would be beneficial in regards to consent. And then others felt that when you, if you found a result, that's when you go back to the patient. So this clinical geneticist said, so if you were to contact a family and say, results have appeared from reanalysis, is this something you would like to explore? Please contact us if you know you want to explore this further. So there's lots of options there. Some of them we think are more appropriate than others. But then the second issue I want to talk about is recontacting these patients, because that was obviously something that some of the health professionals were really concerned about. So obviously, one of the things that came up was whose responsibility is it to recontact these patients, and when do you do that? So some of them raised that if you are a clinician who's moving services, say from one hospital to another, that might create some logistical difficulties. So as this clinical geneticist said, as trainees, we order a lot of tests and we move around very frequently. So, there are going to be a lot of tests that I've ordered that I'm never going to see those patients again. Others talked about this challenge when children transition to adulthood, so similar with the consent, but also with the contacting them. So this genetic counsellor said, thinking of when they move to 18, maybe you roll with, we have found something with your child who's now an adult, we've contacted whatever number we've got. Do you want to know? But if it's the parent who's given consent and then they were 4, I'm not sure about that. And then others suggested that maybe putting the onus back on the family was more appropriate. So this clinical geneticist said some kind of nondescript letter saying your genomic data has been reanalyzed, there may be a potentially clinically significant result, and then that puts the onus back on the patient to provide their own consent, get a referral and see when whatever specialist is either there known to them or within their new area. So I'm just going to give a very brief summary and then give it back to Zornitza. But I think we know that implementing automation genomics will bring a lot of benefits. So speed, efficiency, reduced human error and identifying new patterns, and hopefully more diagnoses. But obviously there are some practical and ethical challenges, and some of them are about integrating this into existing processes. We need to make sure that this is accurate and that there are human checking mechanisms involved, but mainly that we need to think about this consent issue, because obviously there's a lot of confusion around that, and particularly how to recontact patients and make that part of the process. I'll hand back to you.
Thanks. And certainly that work has been extremely valuable in terms of helping us try and design the process around this. So basically, what has happened is that we were lucky enough to receive a large grant from the Genomics Health Futures mission that allowed us to have a go at even building a tool like that, because there aren't actually that many tools that can perform this task. So we were interested in building the tool, seeing what results we get, and then test out some of these issues in practice. And I guess one thing that I really want to highlight is that what we're talking about here and the way that the tool has been designed is to really find the most obvious of obvious diagnoses that are just sitting in the data. So we're not really after finding anything speculative or anything unrelated to the original clinical question that was asked, but just going back and trying to find the really obvious answers that are sitting there. So the idea is that stored data would go into this reanalysis program. It will have that initial cycle of reanalysis, so the data might be a week old, it might be a year old, it might be 5-year-old. So it will have that initial cycle, and the older the data is, the greater the chance of picking something up. But once that initial cycle is complete, it will then enter this iterative cycle where actually we're churning through it quite frequently. And the way that we've designed the pipeline that we're running at the moment is that we rerun the analysis on a monthly basis, but this could easily be daily, or it could be 3 monthly, or whatever you want to set it at. But that we will have these iterative cycles that then pick up the new findings very close to when the new information has become publicly available. So for example, the gene for the condition is discovered today, is published in a journal. We wanted to build something that is able to find it tomorrow and not in 2 years' time, which seems like a funny interval to pick. So we have, I'm sorry to disappoint some of the members of the audience. I'm actually not going to spend any time talking about the technical details of exactly what we've built. But the point is we have built the pipeline, and we've been very lucky to partner with the Centre for Population Genomics in doing that. So the pipeline's been built, and what we have done is we've been quite keen to understand its performance, because a lot of the questions that we did get asked, particularly through the focus groups and the surveys, there's a lot of concern, particularly from professionals, to try and understand how good is this tool and to what extent can it be relied, and what are the workforce implications of something like this. So what we've done is try and understand its performance in data sets of both that contain known diagnoses as well as undiagnosed patients, so a mixture. So when we run the pipeline through something like a data set like that, we know that it picks up between 74 and 81% of the known diagnoses that are in there. So that's the first thing to say. This is not as good as a human. But it is pretty good, and actually we've benchmarked it against some of the other automated pipelines that are available out there, and it outperforms them, although everyone says that about their pipeline, obviously. But the other thing is that it returns a very low number of things for us as humans to look at. So between 1 and 2 variants per person in that initial run of reanalysis. Once the initial run of reanalysis is done and you enter the iterative cycle, in the iterative cycle it only returns 1 variant per 100 patients. So that's a very low number of things for us in the laboratory to be looking at, because none of us want to be now overwhelmed by output from some automated thing. The other point that I really wanted to make is the way we've set this up is that the pipeline produces candidates, but they are all reviewed manually by somebody who's very skilled. And if we think they are likely to be diagnostic and providing an answer to the original clinical question that was asked, the process that we've put in place is that we actually contact the clinician ahead of time at the moment to say, hey, this has come up. Is there any reason for us not to proceed with assessing it and issuing a report? So that gives them an opportunity to say some of or raise some of those issues that they might be aware of. And then if everyone's agreeable, then we forward it to the laboratory. The laboratory goes through their normal process of assessing the variant and issues a diagnostic report. So there's a lot of human intervention in there and safety checks. So what we have done is then apply this prospectively. We've taken a whole bunch of cases that are unsolved from the rare disease cohorts that were tested through the Australian Genomics Health Alliance, which is a national project that assessed the utility of genomic testing across a range of rare disease indications. So that's nearly 1,000 unsolved patients from that. We have also deployed it through our clinical laboratory, VCGS, which is based at the Murdoch. So far we've run just over 2,000 of our unsolved patients through the pipeline, and the pipeline's also been deployed in the US. So just to tell you a little bit more about the types of data sets that we have fed in there, by far the commonest reason for testing has been neurodevelopmental disorders in children, but we also have a very large cardiac cohort and a very large renal cohort in there, etc. Most of the data came from children, as expected, so less than 5 years of age, but actually the full range of adults right through over 65-year-olds at the time of testing, and just a breakdown of the exome and genome data that we have fed through. So we've reanalyzed now data from over 3,000 individuals. Actually, my numbers are a little bit, they keep on changing every week, obviously, so we're now up to 150 new diagnoses. And there's many different reasons for why we're getting these diagnoses. So in the purple, yes, this is knowledge about completely new gene disease associations, things that were not known at the time when we first did the analysis. But the other parts of the pie chart are actually quite interesting. The red part is new knowledge about variants that we did put on the report, but now as time has passed and the same variants have been observed by other diagnostic laboratories, or we have changed our mind about how things should be classified, we can now bump them up from being variants of uncertain significance to being the answer. And then the yellow part of the chart are things that we could have picked up the first time around, but we didn't. And we've learned a lot about how best to analyse data, but sometimes, so there's two basic types of error there that this pipeline's rectified. One of them is clinicians requesting a very narrow analysis when in fact the patients would have been better off having a broad analysis of their data. And the second part of that yellow bit of the pie chart is the laboratory having overly restrictive rules and filtering variants out that were in fact the answer. So the yellow bit is rectifying the mistakes of the past, and the blue bit is bioinformatic improvement, so we can now analyse for additional variant types that we were not able to do 5 years ago. So lots of different sources of increased yield, which is what we were expecting from the literature, but I guess more than half the diagnoses are things that they're not necessarily mistakes, but it's nice to be able to go back and fix them, because if that person had the test done today, they would have had a different answer compared to it having been done a few years ago. And this has just allowed us to systematically go back and rectify those issues in our data sets, something that we can never do manually. The other thing, and this is just my last slide, the other thing that's been interesting and perhaps a little bit unexpected, we kind of thought we will get a really good yield in the neurodevelopmental disorders group because a lot of the new gene discovery is there. And in fact, we thought we won't even bother with the cardiac patients there, low priority, we're not really going to get additional yield. But actually the yield is the same, and in the cardiac patients, it is the improved knowledge about which variants cause disease versus improved knowledge about which genes cause disease. We've had lots of lovely feedback. I do send a personal email to every referring clinician that's getting something out of this pipeline, just to make sure that they're okay, because of all the things that came up as part of the focus groups. We have so far encountered every possible scenario that you just mentioned, but so far people have been very willing to handle that. So yeah, I'm going to stop there. Lots of people have worked on this. And yes, we're happy to take questions and discuss.
Thanks, Zornitza. I think we might hear from all of the panellists before we have the discussion, but if there are any questions that are points of clarification, then now might be the time to make them. So this is something that is incredibly valuable, fantastic presentation demonstrating the value of doing this, but it's also something we're not currently very good at. This is an effort to get better at it, but generally speaking, we're not very good at it. And it seems that to get better at it, we need more than just funding, because just having the funding there isn't enough. We need to incorporate it in existing processes, and we need to address some of the concerns that sit particularly around recontact and consent, so everyone is confident that what we are doing is appropriate. So let's move on then to look at recontact and consent. And can I invite two people up to speak next? Associate Professor Cathy Quinlan, a paediatric nephrologist, clinician scientist, principal fellow and academic lead for graduate research at the Royal Children's Hospital, the Murdoch Children's Research Institute and the University of Melbourne, and Grace Gaskell, who is a 23-year-old kidney transplant patient. Two people who have experience of recontact, both of reaching out and recontacting people, and also of being the person who is contacted. So from your experience, what are some of the things that we need to be thinking about if we want to move towards good practice and an understanding of what constitutes good practice in relation to recontact in particular?
So hi, I'm Cathy, and I'll let Grace introduce herself in a second. But thank you so much for inviting us to come and talk about this today. We thought it would help to give a human perspective on what this actually feels like when you're on the receiving end of one of Zornitza's friendly emails telling you about a new result. But also a massive thank you for giving me the chance to share a stage with Grace, who's been an impressive individual since her teenage years. So it's really nice to get to meet up with you again as an adult. So do you want to start?
Sure, yeah. Well, as they said, my name's Grace, and when I was 14 years old, I was diagnosed with kidney disease, and 3 months later had to have a transplant. So I learnt about kidneys very quickly. And Kathy was my doctor at the Royal Children's. She met me in the emergency room on that day. And so I had to find out a lot about kidneys and a lot about my disease without knowing what caused it, because I had just really baby kidneys and they never really knew why. And so I kind of have lived up until now with just, you know, the doctors saying, you're so lucky, or, you know, it's so random. And then when I was, I reckon 2 years after my transplant, they started the genetic testing. I only got a result just before Christmas. Yeah, so it took a while.
Yeah, so we were lucky enough to get an answer through this reanalysis pipeline, but obviously in the interim, many of the issues that Zornitza and Danya's work had raised had already happened. Grace was no longer a 14-year-old. Her parents, who had signed the consent, were no longer the people in charge, because you are in charge of your own self. She is no longer under our care. And so all of those awkward questions about how do we actually do this were sitting right in front of ourselves. I mean, I think, Danya, some of the issues that were raised, I definitely see that this could have been harder. And certainly I would imagine that if you have a child who has passed on, or a family that are difficult to contact, that you can't get hold of, these things could have all been so much harder. But we still had a real sort of feeling of now I know this information, I know it's going to be relevant for her, I know I have to tell her this, but how do I actually even start that conversation? So without me telling you how I did it, because obviously I think I did it good, maybe you could say how that felt at the other end, to get a call from people that haven't spoken to you in years.
Yes, I thought she did a great job, but I was actually at work when I got the initial phone call from Ella at the Royal Children's.
Yeah, and Ella's our genetic counsellor from the team, but you wouldn't have known her.
I didn't know her, no. And she said, I'm calling on behalf of Kathy Quinlan. And I said, I know her. And then I did feel at ease when I obviously heard Kathy's name, but she said, you know, we've been looking at your genetic testing, and to be honest, I forgot that they even still had that, or were even still looking at it. I didn't even think that the testing would be relevant still. And then they said, yeah, and we've found something and we'd like to talk to you about that. And I was like, well, I'm at work, like I can't do this right now. And they said, no, we'd like to, you know, set up an appointment with both Ella and Kathy to speak about it more in depth. So that was a really great opportunity. And then my mum was also able to be there. So that was great, because she was a bit stressed.
Plus we love your mum. So
yeah.
That was really nice to meet her again.
To see her.
And I think we really thought about what was the best way to contact somebody, because we contact parents and patients in all sorts of different ways. We send letters, we sometimes email people, we occasionally contact them through our electronic medical record, and of course many of us get text messages from dentists and hairdressers and people all the time telling us that we need appointments. This did not feel suitable for that sort of contact, so we went with a phone call. But it's a slightly anxiety-provoking phone call, I would imagine, to be told we found something, we're not going to tell you what it is, but we'd like to see you. That's got to feel a bit strange.
Yeah, it was a bit strange, especially because I forgot that they were even still looking. And so I immediately went to, oh, it's going to be bad. Like this is going to affect the rest of my life in a bad way. Like I was a bit nervous to actually put a name to my condition, because it was always just like random, and I kind of liked that a little bit, that there was kind of just all up in the air. But it was really great to have the Zoom call with Kathy and Ella about it.
Of course, in the meantime, since we've looked after you, and we've had a whole pandemic, and we've moved really nicely to telehealth, so we do most of our genetics consults through telehealth now, which is a really, we think, a very family-centred way to provide that care. And so we were able to deliver the information that way, in a way that allowed your mum to join in the call, but also allowed you to control how that information flowed.
Yes, yeah, it was really good. And also, like, even though I was an adult at the time, having my mum there in that appointment was great, because she picked up on things that I didn't, and she heard things differently and had different questions to me. So yeah, that was great.
Your mum's always had a really good way of looking at where we are right now and then being able to look to the
Future.
big future. She was like that when you were 14 and
Yeah.
she's not lost that ability. So she was terrific in that.
Yes.
And I suppose one of the things that was really important for us in having that consultation was to make sure, you know, there's 400 different genes that cause kidney disease and they've all got different implications for the rest of your body. So we needed to make sure that we were fully across everything. We couldn't just give Grace an answer and say, hey, we found this thing. We don't know what it means. We're going to need to find out some more. We made sure in the time between us getting the result and us actually having the consultation with you that we did any reading that needed to be done and we made sure that we had the answers to your questions, which I think was important.
Yes, and they did have all the answers to all of our many questions. Yeah.
Which I hope was reassuring from
Yes,
that side of things.
for sure.
Yeah, which I think it wouldn't be if you just got a letter. To just get a letter with the
Yes.
report in it would be,
Confusing.
very difficult. And then we have, as our standard in our clinic, is that we then send you out a letter that summarises the things that we've talked about. And then Ella, who's the genetic counsellor, who's worked with me since I started off the service in 2016, always sets up an appointment to have a chat with you again later on. And how did that feel?
Yeah, that was really good, especially because I think it was maybe about 2 weeks after our appointment. She gave me a call and it was really great because I could process what they had said in the Zoom over those 2 weeks and able to talk to my mum more about it and try to explain it to Dad as well. But then when having the second phone call with Ella, then we had a couple more questions, but she was more just able to remind us of what was in the Zoom because we probably had forgotten a couple of things. And then while she was on the phone with us, she also sent us the letter with all of the technical names and information of my new diagnosis, which was great because then my dad was able to read through that, my mum was able to read through that, and we could pass it to some of my friends and family as well who were interested, and then they could come back to us with questions because we knew what we were talking about then.
Brilliant. And then, of course, we also passed all that information on to your treating team,
Yes.
the adult nephrologists who are looking after Grace now, so that if they had any questions, then they had a chance to ask us those questions instead of having to ask you, which
Yeah.
I know you would have known the answers, but it wouldn't have been particularly fair to have done it that way.
Yeah.
So while I think there's a million different ethical concerns potentially about these things, what I always worry about is that when we raise these concerns, that it can stop us offering something that is really useful and really useful for families. And I think it really is just about, I think you set so many safeguards and guardrails in place to make sure that these are results that are meaningful and that they are delivered back to the clinician who ordered it. Is hopefully a good way to do it. It certainly worked out well for us. And I think with all of those processes in place, this is a really positive thing. And hopefully over time, we'll get answers for all of the other undiagnosed patients that we have.
No pressure.
Yes, that's the pressure.
No pressure, but yes, getting the results, it definitely changed my life, especially for future planning. Now, like if I want to have a family in the future, I can actually, plan into that specifically, not just broadly, and I can look at different things and, it says on my papers now why I had to have a kidney transplant, and I look at that and I go, yes, finally. It's so good to have that. And then also, sometimes it can affect other things. So if that happens as well, we can come back to it's because I have this now, which is great.
Power of an answer is pretty strong, and I don't think people who don't have that experience really understand just how important it is to actually be able to explain something.
For sure, yeah.
Consent and recontact are two key issues, as well as being able to integrate it into processes. Recontact can be done well. I think one of the things that struck me is you said when you got the phone call, hearing Kathy's name put you at ease. Oh, okay, this is someone I know, this is someone I expect to have access to my medical records, this is someone I know will be acting in my best interest because they have in the past, even though Kathy wasn't going to be a member of your treating team, if I understand it correctly, because now you'd be dealt with by a team that was
Firmly
for an adult nephrologist, so not paediatric. So that being able to, but if the only name you'd heard was of the doctor that was now going to be taking care of you, there'd have been none of that name recognition, none of that reassurance, and it might not have, I'm anticipating it wouldn't have been as reassuring a phone call.
What would that have felt like if they had said Ella had rung you up, you didn't know Ella in the first place, so if Ella had rung you up and said, so Dr. Bob wants to give you some results, do you want to come in and see Dr. Bob? Would you still wanted to do it? Would it have been more stressful?
I think that I definitely still would have wanted to do it because, like I said before, it has been 10 years since my transplant and I've just been in like a grey zone since then, but I definitely would have been more nervous, and I think I would have definitely wanted one of my parents there, whereas when I had the Zoom with you, I was originally just going to do it by myself and then Mum just came up to see Kathy and then realised what we were talking
Your
about.
Mum just came up to say hi.
Yeah, she did. So yeah, I think I would have put in place having my mum there, and I also probably would have taken the information to my GP, who's also been there since the start, and she would have been that relational contact
And you
in
do have
that
a
situation.
spectacular GP.
Yeah, she's the best.
Excellent.
Fantastic, thank you. Okay, well, we'll come back and I'm sure there'll be more questions.
Great.
But this is obviously one of the things that needs to be handled, recontact, and it seems that there are ways of doing it. But the other thing that we need to think about is consent and how we do that appropriately. And so I'm going to introduce our last panellist of the evening, Heather Renton. Heather is the founder and former CEO of Syndromes Without a Name, Swan, Australia. And Heather's got a wealth of experience when it comes to supporting families and advocating for them. So he's going to say something about from the perspective of that experience and what your experience yourself, and also what you gleaned from speaking with other families. What makes a good consent process, and how do we design one to accommodate these possibilities of reanalysis and recontact?
Sure. Thank you. I think consent is really overwhelming for a lot of people, and parents are so desperate for answers, they will just sign a consent form without actually understanding it. And I think sometimes not everyone has access to a genetic counsellor that will take the time to go through it. I remember the first consent form we agreed to was done over the phone. I really had no idea. I was so overwhelmed. So much was going on, and you don't really care. You just want an answer because life is really, really isolating and stressful. And I think what we do need dynamic consent, but we also need consent forms in accessible language for people. You know, why do we still not have a consent form in easy English, you know, aimed at people with low literacy levels? And, you know, people say, oh, it's an ethical issue. Well, we've been talking about this ethical issue for years. We need to fix it. So that's what I would say with consent. And the other thing is, you know, you sign a consent form and then you totally forget about it. And, you know, we got a letter the other day, or a few weeks ago, about, it said, we would like you to do a survey for because your child has a congenital heart defect. And that was a real shock to me. It's like, my child doesn't have a congenital heart defect. That was way back. She got diagnosed with a small PDA, totally forgotten about it. So it was actually quite confronting. And I think if you were not in a good place, you didn't speak English, you'd be really concerned. So I actually did ring the researcher up and say, what is this? Why are we being contacted? And she said, well, anyone who's seen a cardiologist is getting this letter. So I think we've really got to work out, you know, how we recontact. And listening to Kathy's story, that is ideal. The number of Swan families who've said to me, you know, they've called me on the Friday, but I can't get in for a few weeks. You are so stressed in that time. You know, we got 2 misdiagnoses, and the second one said, I think I know what she has, but I'm not going to tell you because you'll go and Google it and you'll get all anxious about it. Come in on Monday. So what did I do? I Googled her name, found her specialty area, which is what she said she was, limited her down. It was a connective tissue disorder. My daughter did not have Marfan's. She wasn't really tall, had to be Loewe-Dietz syndrome. So I think, you know, I love the fact that, you know, you have the conversation, but I also really like the fact that you Ella followed up 2 weeks after Kathy, because I think, I always say follow-up is so important. You can give a family a result and they can appear to take it in, but it's only when they walk out of the room or 2 weeks later or when symptoms developed that's when you've got to recontact them. And I can tell you from personal experience, it's really hard to get back into a geneticist when, you know, you're getting new research papers, because I'm a bit, I like to know as much as I can about my daughter's condition, so I have a Google alert on it. And then whenever there's a new paper, I send it on to the geneticist, and I'm saying, you know, can we see you before we leave the children's hospital? But they're so overworked, you know, it's a workforce issue as well. So I don't know what the answer is, but I think we need best practice guidelines, national best practice guidelines, so people know what the procedure is. Like with Kathy, you know, in this situation, you need to first make a phone call, make sure you can see them within that week, and tell them that at the consent process. And I liked, you know, the idea you have that conversation at the start with the consent process, but also if there's a negative test result. You know, it should be fluid. You should keep having these conversations. Transparency and good communication have to be the key. You sound very passionate about doing things right, but we need those guidelines and best practice so other people know how to do it, because they're not all going to be, you know, like Kathy, but we hope they are.
Can I say something?
Yeah.
Well, one thing I would say is we've worked for the last 18 months on mainstreaming genomics within our department, which means teaching nephrologists, well, across Victoria, but specifically in my department, teaching all of the nephrologists that you also knew to do all the stuff that I do as well. And to make part of that is teaching them to be able to consent patients and do that well, and support them with a genetic counsellor to do that well. But we've also really worked on the language that people use, exactly like you're saying, that things shouldn't be written in technical language and they shouldn't be communicated in technical language. So we've created movies for patients that they can keep over time, so that they can bring them home, they can show them to other people, and so that they can understand that over time. And in that 2-week period, that 2 weeks, it's wonderful that we contacted Grace again 2 weeks later, but that's our standard practice. We do that with everybody, positive or negative results. So we are working really hard in our little small pocket of things. We are working really hard to make it that it's not that what I do is exceptional, but that is standard practice.
That's good to hear. You know what would be really good? If all research papers published a plain English summary as well that you could give to patients. That should be standard. Because you're doing the research for the patients. You want them to understand it.
And that's what Twitter was fantastic for. Twitter was fantastic for discussing papers, actually getting a chance to discuss with the author of a paper what something actually meant, and can you explain that to me? I don't think we've really gotten a forum since then.
But one thing I didn't like is sometimes I'd find out that we were part of a research process project, and the paper's been published, but we're not told about it when we've said, can you let us know when your paper is published? And that happens all the time. Sorry.
Okay, that's infuriating.
You know, I've got to have something to whinge about.
Okay, thank you. Good. Thanks very much. Right, we're going to move into just a panel discussion now.
Thanks, Martin. Thanks to the panellists. Extraordinary stories. I'm privileged to hear from you guys in particular. Heather, you said something that really resonated with me, and that is that you had received several misdiagnoses in the clinical journey for your children. And I wanted to reflect that back to Professor Stark and just ask you, you know, does someone like Grace, does her test get removed from your reanalysis pipeline now? Is there a risk that she could be contacted in another 10 years with a different gene? And how are you handling this conflicting information?
That's a really good question. We haven't got to that part yet. So at the moment, yes, we are removing the solved cases from the pipeline, but definitely we know that there's a very small number of tests where we have issued the diagnostic result, but in light of new knowledge, we need to backtrack on that, and we have not yet designed the pipeline to do that. We do have some processes in place to pick those up through other mechanisms, and that's a much more distressing piece of information to convey both to the clinicians that were involved and to families, but equally important, potentially even more important than getting the new diagnosis. So I think that will potentially be a future iteration of this pipeline. Again, we need to automate this process as well, because we do know there are some erroneous results out there in the other direction. They're important to fix as well.
Anyone else? While you're thinking of a question, can I ask, how do we ensure that it's not a surprise when people get called, particularly when what they're being called about isn't the condition that they were originally being treated for? So, Grace, you knew that you had tests taken in relation to your kidneys, and so you were called and it was about your kidneys, and so that was all consistent with kind of what you understood the testing to have been done for. Although you might have forgotten about it, when you were reminded, it didn't seem out of place or surprising. But when you start analysing a genomic sequence, because as you say, Zornitza, if we get to the point where we have an entire genome stored for our entire lifetimes and perhaps beyond, because maybe it's relevant to our children and beyond, there's all manner of things that we might be being recontacted about without, maybe even recontact is the wrong term there. We're being contacted for the first time about something that we were not originally, we didn't see the doctor about in the first place.
Yeah.
So, question to you all really, how do we ensure that kind of contact, if it's appropriate, doesn't come as a surprise and isn't unwelcome, or at least it's not an unwelcome surprise?
We haven't gone there because all the feedback that we've had, so we've spoken to a lot of people in the design of the project, and all the feedback that we've had is that we need to stick to the original reason for the test and not go looking wider, because definitely the consent is not there and it raises many more issues. So we have very much stuck to the original reason for referral.
But it comes down to communication and consent, I mean, more than anything else. So I know that everybody has been through our service. I have consented. I know that I have told them all of this. I also know that when I've given somebody back a negative result, I have said, listen, we're going to keep looking at this. I might go to a conference. I didn't know when I gave you your negative result that you were going to do this amazing stuff. But I would have said something along the lines of, I might go to a conference next week and find out about a new gene. And if that happens, I'll contact the lab and I'll ask them to look at it. So you would have been aware somewhere at the back of your head that this could yield information in the future. So I think provided we consent patients, but we also communicate the fact that we might get back to you in the future, this should all be okay. Dynamic consent would be a fabulous idea, of course it would be, where people can continually go in and out and say, hey, I'd like more information or less information, or you can use this for my family or you can't. But in the absence of that, being really clear when we consent people to start off with, I think is the most important part.
I just want to share an experience with us. So when we first started our diagnostic journey, we were actually told that they did probably a microarray on myself, my partner. They ended up doing my siblings as well as our daughter and our son. And they discovered that myself, my brother, I don't think my daughter had it, were missing 4 genes in the X chromosome. And they told us about that and said, well, it causes really dry skin. Now, we didn't ask for that information. That we were just told that wasn't the genetic cause for our daughter. So they're kind of dropping little, I don't know whether that still happens today, but it was information that we weren't prepared for, but it did. I was kind of glad because we just thought my brother had really dry skin growing up and our son, yes, has the same and it's hereditary. Now we know there's an actual cause for it. But I didn't ask for that information. So I guess, how much do you give? And
I think ideally when a sample is being done for you, we're saying to you, hey, look, we're going to do a microarray if that's what we're doing. That's a really high level look at all your genetic material. We could find out anything here. What do you want us to do if we find out something unrelated? If we find out that you've got funny shaped ears, I don't know if you do, but if you have funny shaped ears and we find a gene for that, I always pick on ears because no one really cares what they look like. If we find out that you've got funny shaped ears because you're missing a piece of genetic material, do you want us to talk to you about that, or do you want us just to focus on the information about your daughter? So we would say that to you in clinic up front. Of course, to be fair, there are many things that we say that people don't always remember that we say. There is that. We may communicate it in a poor way. We may communicate so much information that nobody takes anything in. And we may not provide it in a written form to back that up. But ideally, we should be telling you this is a possibility.
I can't recall that being done, but as I say, parents are very overwhelmed. And I know, I mean, I used to always say to Swan parents, take someone else into the appointment with you, because I know when my partner and I would go in, he'd hear one thing, I'd hear another, and we, talk about it afterwards. And I go, no, they didn't say that. I said, yes, they did. So I think, take a support person, and probably, you don't remember everything, but parents usually remember the people who break their dreams, and they can often repeat it word for word, that conversation, many years later. So just be aware.
I would say, as someone who's walked into the room and broken people's hearts, like your mother's heart when I first met you, we remember that moment too. I remember every single thing about that day when I went into the emergency department on my bike to talk to you guys and tell you everything. Because the time when we do break your heart is also a big moment for us. It's not as big, I appreciate that, but it is usually a formative time for us too.
Yeah. I think also when I got my results, then of course they wanted to test my parents, and they did say that. They said, you guys said, if we find something else, would you like us to tell you in their genetic testing? And of course they just said yes, no worries. But my dad was so stressed that they were going to find something else that wasn't related. And then he ended up having the gene that caused my one. And he was like, oh, I'm glad that it's only that and that everything else with me is fine. And I was like, yeah, but I have this because of you. But they definitely had that full consent, and they got emailed papers and everything as well. So it was done really well from my experience.
I was just going to say, having spoken to all these health professionals, and some of them saying people haven't had enough consent. Now, the consent forms they have say something about the fact that there might be some future things found out, and you might receive results in the future that are related to the condition. But actually, it seems like people aren't necessarily talking about that in the same way that you do, and so that is obviously a little bit concerning. The fact that the people who are doing the consent process don't feel like they're covering this enough. And it's something that I've thought about a bit, because I've been involved in a national consent form initiative run by Australian Genomics. So we've been trying to develop new consent forms that would hopefully be used throughout all of Australia to try and get some kind of consensus and some homogeneity across the board. And that's been a really traumatic process. But the plan is to try and make that happen, because we want to make sure that this does happen and people have the same information across the board. Did you want to comment on that?
No, but it goes back to some of the earlier comments about learning from this experience and trying to develop some best practice guidelines to help people's practice. And I think to some extent the variability in practice in terms of consenting over the past few years has been because we didn't have something concrete to offer. It was always an idea, a possibility in the future that we could do automated reanalysis. So maybe some of us felt more confident about that happening versus other people who didn't want to overpromise and therefore glossed over that part. Yeah.
We have another question here.
Yeah, thanks, all panelists. I'm just wondering what would be the cutoff for contacting a patient. So if a uncertain result changes into a likely benign result, or no, very clear. So you only contact them if it's very
clinically significant change. Yeah. So a diagnostic result at the moment. Yeah.
Okay.
Hi, I have a bit of a two-part question. Firstly, when the guidelines are established as such, is there going to be discussion with patient organisations such as SWAN, and obviously a bunch of different patient organisations? And if so, my second part of the question, being that the statistic at the moment is that, quite a few children pass away before they turn 5.
Yeah.
So how would you ethically bring this up, particularly if you don't know if that child has passed away? But that also goes into family planning of that family.
Absolutely.
Potentially as well. So how would you sort of bring that up?
Yeah, maybe I'll answer that part of your question because it's uppermost in my mind. We have contacted a number of families in that situation, both for deceased adults which can also be hard in a different way, and deceased children, and pregnancies that have been lost and that we have now found the answer. And I discussed that with all of my colleagues that were going to be involved. All the feedback from them was, yeah, this is going to be tough, but actually it's potentially really important for the remaining family members, so they all felt pretty keen to do it. Going back to your first question, I think I'm treating this at the moment as a demonstration exercise that this can be done. There are lots of things that we'll need, it's part of a research grant, to bring it into routine practice. There'll be a whole bunch of other things that we need to address. One of them is funding, being able to deploy it in the diagnostic laboratories outside of this research project, and doing lots more consultation, both with professionals and with patient support groups, etc. So there's lots of issues that will need to be resolved right from policy level down to the practicalities. So this is just at the moment a demonstration and an opportunity to get some practical experience under our belt.
Can I talk to that as well? So I'm on the Education, Ethics and Social Issues Committee of the Human Genetics Society of Australasia, and we develop policies and position statements around these kind of practices. And we have a member of our committee at all times who is a patient representative, and so we make sure that the patients are always involved in the processes.
And I guess I'm a nephrologist, so a kidney doctor, and we have a group called the Kidney Crew, who are made up of families and patients who've experienced different forms of kidney disease, and we run everything new past that group as best we can, so that they advise us on how people would like to hear things. When we originally started our service, we also gave families like a test about 3 months after the test, 3 months after their consent, to see what they remembered and how they interpreted it and how close were they to the truth, so that we could understand if how we were communicating things was actually accurate. And we've done pretty well with that stuff.
Clara.
Thank you all. It was so interesting, Grace, to hear about your experience as a genetic counsellor. I don't often get the chance to hear about people's experience afterwards and what that's been for them. So thank you. And this is a sort of maybe an extension of the last question. So Nancy, you said there's still many things to do. Will there be the opportunity to interview the people that have been getting results back through your project to get that experience, that qualitative experience from them as well?
We're thinking of doing that with the health professionals. I haven't really thought about doing it with the patients, but that's definitely an option. We would have to. There's money left in the grant, so
we can have a chat afterwards.
Okay, any other questions? Thank you.
This is a question more so for Heather. So you mentioned how your daughter was involved in a number of studies and you were frustrated about not hearing about papers being published, particularly using their data. I know I'm a researcher, but looking more so at the technical development of pipelines, and patient data is really useful, and the consent process obviously is encompassing of that. Really useful for verifying the technical pipelines, making sure they work appropriately. However, these papers and research tends to be at a technical level that's not so much about the analysis of the findings, but verifying the systems. From your perspective, how useful is it knowing about these steps that are more for the technological development as opposed to the analysis development? Because for the field it's very, very useful to have this data, but I can imagine as a patient it's not as useful.
I guess the papers I'm interested are the ones about symptoms that might develop. And for me, for instance, I read a research paper on my daughter's condition. She has FOXP1 syndrome, and it said, we suggest that patients with FOXP1 have a renal ultrasound every 2 years. So I sent that off to the geneticist, of course, but I also raised it with her paediatrician. Now, had I not read that research paper, we wouldn't be having a kidney ultrasound every 2 years, and she could end up as one of Kathy's patients if that was, heaven forbid. But so I think it is really important to keep abreast of the research when you have an answer. you know, but so many people don't have an answer, and then that's really hard. And I always say, you know, knowledge is empowerment, and empowerment leads to informed decision making. But if you don't know, it's very hard to know what to watch symptom-wise, you know, what you should prioritise in terms of treatments and therapies. So, yeah, look, I think, yes, research papers, you know, is good information, but it's also helpful for parents. And, you know, research should always be done in collaboration with patients or patient organisations, co-design, all the way from this concept stage all the way through to implementation. And we're only slowly picking up on this at the moment. And I think, you know, would it help if we had consumers on ethics boards as well?
I work at Peter Match, so just across the road, and as a part of our research, big about bringing in patients and consumers into research. So I can verify they're doing that there too.
And can I just do a pitch? Family Engagement Research course is being run by Healthy Trajectories starting July. You can still register if you want to know more about how to partner with researchers and consumers.
So I would say our process is that if we have a paper that's published that is, you know, heavily contributed to by a couple of patients, that we let them know about it in advance, that we send them a copy of it, and if it's appropriate that they contribute to the paper in some way. We have a newsletter so that those sort of bigger papers, the ones that describe a few hundred patients where we're not going to contact everybody individually, that they can get a copy of it or at least know that it's been published, and that we'll send them out a print of it or a PDF of it if they want it, because it's their information. And you're absolutely right, you might read through the supplementary information and find out something in it that is important for your child's care, and you are always going to know them the best, so you should have that information.
It's hard though, because I do appreciate that, you know, geneticists cannot keep abreast of every new research or symptom, and not all parents are like me who are, you know, very proactive, want to be involved with learning more about the condition. So, and I think sometimes, you know, going back to, you know, the original conversation about, you know, who should contact who, and, you know, geneticists might say, well, check in with us every 2 years. Parents are so overwhelmed, they're so busy. Every day is a struggle, I can tell you that firsthand. So, you know, you forget 2 years can go like that. So, you know, we've got to even automate,
Yes.
you know, SMS or on the portal, you know, would you like to have another consult? So we've got to get that bit right first as well. And I mean, and I think what you're doing is fantastic, Zornitza, and why wouldn't you do this reanalysis? You know, the government just has to fund it, fund more workforce, easy, no worries.
Okay, I think probably one last question. George?
Thanks for coming today. This is a question about automation and informed consent. So I guess you're expecting to scale up the genomic testing in the next couple of years. So how do you gauge the level of informed consent from patients and like make sure they're of adequate understanding of the process they're going into? Especially since I guess you'd expect like the workforce capacity is probably not going to be there for a bit.
It's a tricky question. I mean, we do ask ourselves that all the time. So these days I work half my time in our laboratory rather than seeing directly patients myself. But at some point, I'm going to have to trust everyone else in the system to have done their job rather than continue to second guess whether they're capable of consenting patients. So there's lots of things that go into that. It's developing the appropriate consent material. So Danya talked about nationally agreed forms. It's not just about the form, there's also the supporting materials that go with it. And Kathy talked about, you know, they can be written, and a lot of work has gone into that. Kathy's done fantastic work putting those into videos, and you know, there's been heaps and heaps of work and a lot of training of the workforce as well in terms of mainstreaming. We can't always guarantee that everyone has done their job to the right standard, but I think we have to go in there with that trust that health professionals generally want to do the right thing and do it to the best of their ability rather than sitting back and second guessing whether that's been the case. Anyway, that's my attitude.
I just want to comment on, I guess your question was about whether they've given informed consent for the reanalysis or the fact that it's automated, because they're two different things. And I think obviously the patients that have been have had consent from the previous, from the last whatever number of years, automation wasn't something that would have been talked about in those consent processes, even if they've discussed the fact that it's going to be that reanalysis might happen. They're not going to be saying that, and there might be a machine that does that. Now, some degree of automation has already been happening for quite some time. It's the degree of that, and I think that that's something we need to think about, is how much does that matter? And I asked a lot of my participants across all 3 different groups about that, and we had very mixed responses about whether people thought automation mattered in terms of what patients need to know.
And I guess providing some reassurance in that there's still a manual process and manual oversight, and understanding the limitations of that, and that being directed more towards the health professionals. So, for example, knowing when to order a manual reanalysis versus relying on the automation.
But when it comes to the informed consent question, so when Grace's result came up, I knew Grace, I knew what hospital she was now in. I had a quick call with them to make sure that life was okay. But if I had not known you, if it was another 10 years down the road, the other option would have been to ask the healthcare professionals who were involved in her care to have supported them to deliver the result back. And if that was your GP, maybe that would have been the appropriate way to do it. So that the GP could contact and say, we might have something that I think we need to talk about. Would you mind coming in to making an appointment in the clinic in the next week or 2? And then to do that with the support of the genetics team or some education in advance or a genetic counsellor, and to give that information in the way that meets the patient the best. And opening that conversation with, do you remember getting a genetic test done? Did you know that we keep looking at that result? Is certainly one way to do it. And that's kind of how we're checking that consent process has happened, but also making sure that it's actually been heard.
Okay, thank you very much. So, there's lots of good people who are wanting to do good things, but there's some uncertainty still because we don't have a common understanding, as evidenced by the survey results, common understanding as to what the right thing to do in these situations, what it always is. But there is a way of doing it. There is a way of doing it that both patients and professionals recognise to be appropriate, but we need to help people understand what is good practice in this space to give them confidence that if they walk this particular path, they're doing the right thing. We have guidelines internationally. We don't have them in Australia at the moment. So that's one of the things that I think we should be trying to work towards, and hopefully this conversation has contributed towards an understanding of what the need is and the urgency and the importance of getting this right. Can I ask you all please to thank the panellists for taking part in a fantastic conversation tonight. Please keep an eye on the collaborative website for the next event. There will be other events happening this year. Otherwise, I think there is still an opportunity perhaps just to get a last drink before we finish, continue the conversation informally, but otherwise safe journeys home, and thank you ever so much for giving up your time and joining us for this conversation this evening. Thank you.